Welcome to Morning Infusion with Dr. V, where we are intentional about connecting you with other entrepreneurs that have overcome and want to provide value to our audience. It's Dr. V here, where our coaching program teaches nurses to work from their computers anywhere around the world, making money and owning their own time, which we're working from anywhere around the world, making money and owning our own time at this time. So today we have Dr. Celia McIntosh. So, Dr. McIntosh, tell us a little bit about
Yes.
yourself.
Thank you for having me, Dr. V. I really am very honored to be a part of your podcast. So, a little bit about me. I'm a nurse practitioner, doctorally prepared nurse practitioner, have been in the healthcare sector for over 17 years, doing a variety of different things, whether that's being in the clinical role, education role, or just being a human trafficking and human rights activist. I'm currently working in the neuroscience center, been a nurse practitioner in neurology for about 10 years, but I've branched out a lot over the last 6 years to do a lot of advocacy around human trafficking, social justice related to police brutality, and just Black maternal health now.
I love it. I love it. I love it. So now tell me a little bit about, and the reason why I'm asking is because I struggled, I used to work in the emergency department. And so one of
Yes.
the things that I struggled with was identifying people who came in who were, because where in my emergency department, we were right on the outskirts of two interstates, right?
Mhm.
And so apparently we had a lot of human trafficking that came through. But how do you identify those people that come through that may be, a part of that, may be victims to that?
Right. So some of the biggest red flags oftentimes is, how people show up. Are they speaking about the life? That's the situation that's in. That's the language that they reference. Are they presenting with someone that seems to be dominating the conversation? Maybe someone that's a gatekeeper in the conversation. They say something, they're always interjecting. You're in a room with them, you want to do their exam, you want to get their history, and they keep talking over this patient. Is the patient presenting very anxious, or very withdrawn from you? Um, are they a frequent flyer? That's one of the things, because oftentimes traffickers will take their victims from state to state. So many times you will see that there's no consistency in the plan of care or the treatment follow up, because of those gaps in care. Other things, psychological components, physical beatings, just the different types of trauma they can get. But I would say if you're in the hospital situation, it's oftentimes going to be someone that's pretty much dominating the conversation. Maybe there's another person, not necessarily a male, but another person with the client or the patient, that just seems like they don't want to leave. So those are some of the main things. But, if the individual is really inappropriately dressed for the weather, you're like, okay, it's summer, but you have all this winter stuff on.
Mm.
Just if they, mental status doesn't seem to be up to par, multiple bruising coming in for a lot of the same complaints, UTIs, STDs, many things like that.
So when they show up, do they always show up? And I'm sure that this is probably not a, always, but do most of the time they show up with the perpetrator?
The perpetrator may be in the waiting room. Sometimes they may show up by themselves. Sometimes the perpetrator will send another, girl with the individual. And the biggest thing is that human trafficking is not just women, or young girls. It tends to affect women and girls more so. But I mean, you have LGBTQINA, you have transgender individuals. The main things are that homeless, runaways, populations that are more vulnerable, will be the ones that are often trafficked, but they're not the only ones that are trafficked. But oftentimes they will. And one of the other big things is language barriers is a big thing. So their perpetrator may show up to translate for them so that they are not recognized. So that's one of the things, but not always, but for the more majority of the time they do. They present with normal complaints. I mean, human trafficking is hard because it's not like chest pain where you're coming in clutching your chest. You know, no one comes in with the chief complaint of I'm a human trafficking survivor or victim. Oftentimes they don't know they're victims, you know, so like I said, they may show up for the physical issue, whether they got choked or stabbed or beat, you know, that may be the main complaint, or abdominal pain or STD. But they often frequent the EDs. I think it was about 63% of victims come to the ED because, you know, it's fast, it's in and out.
Gotcha. So
Mhm.
now how do you approach, like, if you, like, that was another thing too. I was like, well, how do I approach them? Like, what do I say? And if I say, do you find in your work that if you address it, or like, do you say, are you a victim of human trap? And I'm sure that they, like, what do you say to them?
Well, you wouldn't necessarily use that language because, like I said, oftentimes people don't know they're victims, you know, because oftentimes those situations may be, you know, they may think that this is their boyfriend, you know, because there's oftentimes a lot of grooming. But what you really want to convey, you know, just to check in to see if they're safe, if things aren't lining up, if the bruise doesn't look inconsistent, you can kind of normalize the conversation around that, but definitely trying to get a sense if they're safe. If they are with the perpetrator, you want to try to separate them. And some people say, how do you do that? Well, can we walk to the bathroom and get a urine sample? Can we take them back to the x-ray area where perhaps that's a time to have some one-on-one time? Or if you're bringing them back from the triage area and getting them into intake when you're one-on-one with them, getting the information, those are those times to separate them and have that interaction. But definitely finding out if they are safe. A couple other questions that trafficking survivors said that was really helpful is, are you being um, are you being forced to exchange sex for money or anything of value, or are you in the presence of someone that purposely intimidates you? And because we know that New York State has the fourth highest call volume for human trafficking,
Oh, wow.
and yeah, in 2017, there was a public health law that came out and basically said organizations have to have policies, procedures, and protocols and training for their staff. And one of the things that we were able to do as an organization is we rolled out a policy with education about human trafficking in 2020 because of this. Because what we found out, like I said, when I found out about human trafficking for the first time in 2014, it was 9 out of 10 victims coming in contact with healthcare providers, and we didn't know because we never got received any of this education. So, and that was based on a landmark study. So, like I said, the main thing is really trying to convey a sense of, are they safe? And, you know, if the victim doesn't leave at that time, that's not necessarily negative on the healthcare system or you as an individual taking care of them. It could be because it's just not safe. You know, oftentimes when we think about domestic violence, there's a huge overlap, and it takes individuals that have been victims of domestic violence about 7 times before they leave. It's the same with human trafficking, and this is a $150 billion industry,
Wow.
which has been said to be more than Nike, Google, and Starbucks combined. So
Wow.
it yields very high profits and low penalties.
Wow. That's crazy. So that's crazy. That is crazy. So what made you want to go into this work? Why did you want to go into the advocacy for the human trafficking?
Well, so I have a very I have a passion for law and nursing. I've always wanted to be an attorney, and I figured that I wanted to find a way to connect the two.
Mm-hmm.
So I started doing sexual assault kits, became a forensic nurse examiner, and I did that for about a year. And I remember my last patient that I had, and you know, she came in, she had been raped. I had to do her kit, but there were a couple other trainees that wanted to come that night and also kind of see the process. And then we also had 2 people from Restore, so there were like 5 of us in the room with her, you know, and I just remember her just the situation feeling so awkward, and just having her relive the story. And that day I decided I didn't want to do that anymore. I felt like I was getting a little vicarious trauma. And I happened to be walking into work, like within the next few days, and there was a conference happening, and there were tables set up, awareness tables set up outside, and what I did was I walked up to the table, and there was a sign talking about human trafficking, and I was thinking, what is human trafficking? And I just went over to the table and started asking questions. And the minute they told me about, individuals being tricked and forced into this, and being used for money and having to sleep with up to like 50 men a night, I just could not unhear that. And I felt like that was a call to action for me. And I figured I'd been to like three different schools of nursing at that point, and no one had ever mentioned anything about human trafficking to me. So I figured, if I don't know, a lot of my nursing colleagues don't know as well. And that's when I started doing my own research and found out that in 2014, that landmark study came out and basically said 88% of victims come in contact with healthcare providers, which is 9 out of 10 patients, and we didn't know. So from there, I just really started getting involved in that with that organization, and then really started doing, continued to do my own research, and then became the president of that organization and continued to educate different organizations, like faith-based, medicine teams, social workers, and that's pretty much how it started. But it was, to me, it was a call to action and being able to relate with some of these situations. You know what I mean? When you think about the population that it impacted, people that were homeless, people that were have mental illnesses, maybe disabled, and the biggest predictor is child abuse. So if someone has been, a victim of child sexual abuse, they're at higher risk. So, like I said, it was just those different social issues that said anyone can really be at risk for this, and I need to learn more about it.
Gotcha. So now you are at the pinnacle of your, educational process. So
Mhm.
tell us a little bit about that. So tell us why you went back to school to get your DNP, because that's what you have, DNP.
Yes. So I actually, in my full-time role, I'm a nurse practitioner in neurology, and I probably was about 2 years in my career. I think 2 or 3 years in my career, and I'm always on the quest for learning and new knowledge. But I went down to the emergency department. We were called down there for a stroke, and I went to see this patient, and everything he was describing was depression. And
Mm,
I said, "Okay." And then his wife, he was pretty aphasic, um, couldn't get his words out. And I remember his wife saying to him that, "Do you feel like I'm a burden? Like, do you feel like I'm a burden to you?" And he's a burden to her. And he just started crying. And apparently he had tried to kill himself like 6 weeks prior. So
mm.
in that moment, I said, "We don't screen for depression here." So that was the impetus for me going back for my doctorate, because I wanted to implement a depression screening protocol for acute stroke patients. And that's really why I went back. But it was definitely because of the quest for new knowledge. But since that, I did do that project, and I have published it a long while ago. But we got the screening embedded into our electronic medical record. So any patient that comes into the hospital that is positive for a stroke, whether by CAT scan or MRI, they will get screened. And when they go into the outpatient clinic, anyone gets screened. But the point was, let's try to get ahead of this. I don't necessarily want everybody to push them on, patients on medications, but maybe if there's depression is caught earlier and we get the medication on board, they're more likely to participate in their therapy. They're more likely to have more motivation. If they have more motivation to participate, then they're less likely to go to nursing homes and have poor outcomes. And then they're less likely to have increased mortality. So it was just a variety of those things, but that was the driving force behind me going back for my doctorate.
I love that. I love that, because we all have our different reasonings for going back for our doctorate. One of the reasons why I went back was because I wanted to ensure that the nurses were assisted. And of course, it was not we're going to talk about advocacy in a minute for
Mhm.
nurses. But, at the end of the day, we thought that was the end all be all. And that's great that you were able to make that change. So, it's interesting that because here, and I think that maybe one of the reasons why it is here because we had this guy that apparently committed suicide at our hospital,
Mm,
and so I so that's one of the reasons. So it is implemented here in the triage process.
mm.
So is it implemented there in the triage process?
So anywhere, I believe it's as long as it's in our stroke order set, we can screen. But I don't necessarily, probably not definitely at the triage process when you come into the ED. For my project specifically, it can be generalized to these other groups, and it could be generalized to, if anyone wants to use the screening, they can. But for mine specifically, it was targeted towards stroke.
Gotcha.
So they probably wouldn't get screened unless they, probably are admitted to the floor because the nurses in the ED probably will, say they're a little bit busier than, the inpatient.
Yeah, and so it was a very quick process. We asked certain questions like whether you had drug use, whether you've thought about committing suicide within the last, however many months. And one of the reasons why we implemented that was because people would come in and they would be suicidal or they would be homicidal, and we would run them through the triage process and we wouldn't know, right? We
Mhm,
wouldn't know that they were homicidal and suicidal. And so we implemented that so that we could then go ahead and pull everything off of them,
mhm,
because what we had with the process that we had was you came through a triage. If you had, if you were suicidal, homicidal, then
mhm,
we immediately eyes on you, right?
mhm,
Nobody took eyes off of you. You always had a one-on-one sitter with you, and then they took you back through the process and took not took all your things. I don't mean to sound that harmful, but
mhm.
you want to make sure that the patient is taken care of, right? You want
Right,
to make sure that they're not able to harm themselves when they're in your organization.
correct.
So that we took all their stuff,
Mhm,
basically, not to
mhm.
take it, but to make sure that they didn't harm themselves with it. So now tell me about you have a business. So tell me about your business and tell me the reason why you went into business from the beginning and how long have you been in business?
So I've been in business, I would say 2021 is when I started
Okay.
trying to develop the business. And it really came out of, so it's McIntosh Advocacy and Consulting. And it's really twofold, but the first part of it is really to help nurses navigate toxic workplace culture and really succeed at work. We know that oftentimes when you think about nursing, a lot of times you hear nurses eat their young, you hear about bullying, and it can happen at all spectrum. It's, from CNAs to PCTs, nurses against nurses, physicians against nurses. So, I mean, the spectrum and management against nurses. So, I really wanted to have some discussions around that. And I had a discussion, I believe it was called Raw Conversations, Racism at Work, as one
Mm.
part. And that, and the nurses that came to that, they talked a lot about the workplace bullying that they dealt with. They talked a lot about microaggressions, and they talked a lot about psychological safety, specifically for Black nurses. So that led me, just in my own experience of being also bullied in the workplace, I really said, well, how could I help, solve this problem? And really, if the organization is not going to change, how can I equip these nurses with some tools so they can be successful until they decide that this organization no longer serves them? So that's the aim of the business, is really to help them navigate these toxic workplace cultures, by using strategies, whether it's emotional intelligence, self leadership, self regulation. And then the part two of it is really aimed at helping organizations improve, quality processes, be more efficient.
I like that. I want, I almost think that the reason why is such a because it's been a culture. I mean, I've been a nurse for 30 years and it
Mhm,
has been that way for the entire 30 years. I feel like it's gotten a little bit better, but I
Mhm,
do feel like as well that we perpetuated by saying that nurses eat their young. You know what I'm
mhm,
saying?
mhm.
So that always, that statement that always goes with that. So now tell me, what are some of the things that you dealt with in your workplace, if you don't mind exposing that?
Oh, yeah. So when I was a bedside nurse, I dealt with, just the snarky responses from senior nurses, not being very helpful. I had literally one nurse tell me that I was hooking up a Pleurovac, and I was a brand new nurse on orientation, and she was telling me to put it the wrong way. And it was just like, you are willing, and I had to check with another nurse because I was like, this doesn't seem right to me. She, told me the right steps in the process to do it. But I just remember feeling like, you are so, like, this is devastating to me that you would really want to harm the patient by giving me the wrong information. So that's in my bedside career what I mostly dealt with. In my NP career, what I've dealt with, just I've had, seen favoritism, and it's racism in a sense, with some microaggression laced with some favoritism, because the favoritism is a towards my predominantly white colleagues are aimed to isolate me, to other me. I see, that there's more time spent with my colleagues explaining the case, resources, where with me, I'm being told, look it up. Other things will be, I have, some providers messaging me, one specifically, my shift starts at 8 o'clock, and he sends me texts at 6:30 in the morning telling me, not to see follow-ups. And then he'll tell my coworker that I'm not seeing my follow-ups. So there's an element of sabotage there. Um, when I don't respond negatively, he escalates, whether that's, trying to perform behaviors like talk loudly to me around other people. So there's witnesses, or recently started, CCing the chair of the department in on some of our communications. And when I question why that is, the statement is, I feel it's necessary, in an effort to make it seem as if I'm the one that's kind of combative. So it's like there is this attempt to make me appear to be this angry Black woman within the workplace. So those are some of the ways. Or one of the other things is that my colleagues will not get this type of behavior. One provider will send me, just pages of text about his expectations, even though I've been doing the job for the last 10 years, even though I've gone through a series of, probably worked with over 20 neurologists in my career and over 15 NPs. That's the turnover for our department. But, basically feeling that he needs to constantly remind me what the expectation is, whereas he doesn't do that to my white counterparts. So there could be an element of bullying, could be an element of racism, but those are some of the ways that it's manifested. But definitely one of the biggest things is the lack of information, because it will impact patient outcomes.
That's right.
Yeah, so those are some of the ways that it's manifested.
That's right. It's one of the things that I remember being in the emergency department, and one of the nurses came to me, and she came to me after, the reason why she was so upset with this particular nurse. She was an excellent nurse. The reason why she was so upset with this particular
Mhm,
nurse, because she felt like this nurse talked down to her.
mhm,
So what she did was she came to me, and she was, because whenever you rapid sequence intubate patients,
mhm,
you do, etomidate and sucks, and you do the etomidate first so that you can calm them, and then you sucks to paralyze them, right?
mhm,
And so I said, look, so she came to me. She was like, well, every time she gets ready to do that, she always asks me the question, well, you're in the middle of an emergency, right? And it's a patient. It's a patient on the table. So
mhm,
what you need to do is you need to give her the right answer in the moment. Okay.
mhm,
I understand that she is what she is, but at the end of the day, you have to react
mhm,
the way that you would react regardless Your
Mhm.
reaction does not need to change regardless of how she does, because at the
Right.
end of the day, the patient is the one who suffers. And that is
Correct.
what we're trying to do. And
Yes.
so when I got in management, same thing. It was, I had a counterpart who was a manager, had been a manager for a very long
Mhm.
time, and I had not been a manager. And there were
Mhm.
all these expectations and things that were said to me that I was supposed to do. However, I did not have the the
Mhm.
the blueprint of what I needed to do.
Correct.
And that was brought to my evaluation that these are the things that you're not doing. Well, you ain't told me how to do them.
Right. Right.
I mean,
Right.
so I mean, and I think that is, I think it's a lot of what you're talking about, toxic
Mhm.
environments, and until everything rises and falls on leadership.
Mhm.
So what they have to realize is that their leadership is the one that's lacking and not where it needs to be. So what
Mhm.
are some of the ways in which you help nurses navigate that?
So one of the things is I have this 8-step formula. It's
Okay.
called How to Self-Regulate and Develop Patience. And with that formula, there's 8 steps within it. But it's really like, for example, your first step is pause. Because what happens is oftentimes when you think about the brain, your frontal lobe is where they make those executive decisions, right? But
Hmm.
when you have um, the amygdala will hijack your brain, especially when there's a threat. So you have this threat of your boss being condescending, trying to humiliate you, embarrass you, or dismiss you, or you facing those microaggressions. You immediately want to respond. So I'm like, in that moment, you have to stop and you have to pause to give your brain time to override the amygdala so that you can make more rational decisions. Because if you don't, then like I said, the amygdala has hijacked your brain, and all you're going to do is make rational decisions in that moment. So being able to just stop for a minute, take a deep breath, or walk away from the situation, say, interesting, I have to think about it, and maybe come back to it at a different time when you're able to process what's happening. But really, and then also recognizing what's happening to your body. Okay, this has triggered you. What's happening? Are your palms sweating? Like, what other things are happening? So you can recognize that and be able to, kind of like I said, avoid the conflict or diffuse it in the moment. So that's just one step, but those are some of the things that I teach. Other parts is really helping them understand self leadership. Leadership may not change, the situation may not change, but your reaction is going to be what matters, because that's what's going to define you. If you respond prematurely, then your credibility is lost, and that's all that they will remember. Oh yeah, remember when she yelled, or she walked stormed out? That's what they're going to remember. So if you're calm and you're calculated, and you think a lot about, and you, like I said, think before you respond, then you're able to make more informed decisions. You don't lose your credibility, and you're just able to be more in control. And then, of course, that's a part of the emotional intelligence, being aware of, how you're showing up. And then, yeah, you're going to recognize their behavior, but understanding that, you can only control you. And then, of course, being able to put it together, because as nurses, I don't think, even though we may hear that nursing is toxic, what do we do when we encounter those spaces? How can you prepare me before I get into the workforce with some of those situations? So that's one of the things that I also do, is put that into practice. We'll go through a case study, and what would you do in this situation, and how would you respond? What could you have done differently? How do you use your resources? But being able to talk about those things, and just have kind of like a framework for yourself of how you're going to show up to these workspaces. And then at the end of the day, it may really be a bad case of Get Out. We've probably all seen the movie. And then at the end of the day, you may just have to leave, and find something, leave the table because it's no longer serving you, or because you're not being appreciated there. But those are some of the steps that we take within this course to get to that, to really help the nurse or the healthcare professional individually.
I love it. I love every last bit of that.
Thank
Because,
you.
you know, when I used to, and I'm a firm believer that every leadership principle that you have ever gotten is deeply rooted in the Bible.
Mhm,
Just what I believe. And so when you're talking about the pause, right? Proverbs 17:28, right? It's the pause. It's the being quiet until your heart can heal. When your heart heals, and I guess that's the amygdala. I guess that's the scientific portion of that,
mhm,
right? The amygdala, okay? You're like, you know, calm back down, calm back down.
mhm. Yeah, yeah.
And then, you know, because I have to pause, right? When people say
Mhm,
things to me that I don't like, I have to pause. And I hadn't
mhm.
always paused. I mean, I'm an ER nurse to the core of who I am. I mean, you're gonna get
Right.
what you get, right? Typically.
Mhm,
And so, and that's, you know, the overriding of the amygdala, I guess. And so,
mhm,
and I never knew that. I never knew that
mhm.
that was a thing. But I
Yeah.
love everything that you're saying, and that is much needed in the workplace, in order for us to succeed, because you want to answer with a soft answer,
Mhm,
right? So that you don't appear to be that mad black woman, right?
mhm,
And that soft answer turns away wrath, and that's what they talk about in the Bible, right? The
mhm.
soft answer turns away wrath. So I love every last bit of that.
Thank
So
you.
where can they, if they are dealing with these toxic environments, tell me where they can reach out to you at.
Well, currently they can, inbox me or message me. My email is celia@macintoshabvocacy.com. But
You
I
on
am on
TikTok?
LinkedIn, I'm on
You on TikTok?
TikTok, I'm Doc McIntosh or the Advocacy Nurse on TikTok. I'm on, Instagram as well as Doc McIntosh. Also, I believe the Advocacy Nurse on there, and I'm on LinkedIn as Celia McIntosh.
Sweet. So, reach out to her if you're dealing with toxic environments, so that you can get some assistance from her. And so, again, we will be having our master class. We're having a master class. It's coming up on September 6th,
Mhm,
from 6 until 8. It's going to be a master class for if you want to go from being a bedside nurse to being a six-figure entrepreneur. So I look forward to seeing everyone on there, but please reach out to Dr. McIntosh. If you are staying in the environment and not trying to go into business, Dr. McIntosh can work it out for you, because everything that she is saying is things that I actually practiced. I wish I'd have had her, but it's things that I actually practiced, and they worked for me. They worked for me because you have to be, do, have. You have to become a different person in order to
mhm.
do a different thing, in order to have what you want.
Yep,
So she is teaching you the practical steps of that and walking you through that process. So thank you, Dr. McIntosh. And you guys have a phenomenal rest of your day.
thank you.